So just to want to clarify, we learn, every one of us learn the lever system in our college days. Mechanically advantage, mechanically disadvantage, and so many things we learned it. We learn momentum, how force applied and everything. But simply, which we want to add one more point on it, the momentum has two varieties. One movement has to happen, the movement which has a resistive force, also the movement is required muscle force. Just keep these two things on your mind. The movement is required muscle force to produce the movement. The movement has some resistive force. Maybe the resistive force can be the gravity, general body, arm weight, or any weight if you hold. Okay, it's much clear. From here, when we move on, the movement was happening through the some axis, right? Some axis. Without any axis, the movement doesn't happen. So considering that situation, movement axis to muscle attachmental area distance called effort arm, which is effort is going to apply by your muscles and joint, that is considered as a effort arm. Clear so far? Just shake your head, I will move. Because without any writing or something, I'm explaining through mouth, it's difficult to catch inside the mind, I understand. We'll plan something for the board-based teaching.
So can you please explain once again?
Yeah. So every movement happen through some axis. In a sense, axis to muscle attachment area distance called the effort arm. The effort which is produced internally through the body, that is called effort arm. And the same axis to maximum amount of resistance distance. The resistance distance called resistance arm. If effort arm is more than the resistance arm, that movement considered to be a mechanically advantage movement, it is easy to perform. Because the effort arm is internally, which muscles produce, is more than the resistance arm, the movement will be easy to produce. For example, the resistance arm is more than the effort arm. It is tough to perform. Mechanically disadvantaged position. Okay. Again, this is the overview. I will come in depth. We will discuss about lever system with a lot of movement example in upcoming weeks. So when I talk about the torque, when I explain this, it will be useful. So, clear, guys? So overall understanding, the joint axis to torque distance will be more. The distance will be more resistive. For example, resistive arm distance will be more. The movement makes more tougher. Correct? Exact opposite manner, the axis of rotation to muscle attachment distance is more. Muscle insert on certain region, attach on certain region, it pulls the bone and moves, right? That distance is more, that will be an advantage. If muscle distance to the axis is more, advantage. Easy. Muscle distance is closer to the joint, is tough. Resistance distance is too much, is tough. Resistance is close, is easy. Resistance distance is indirectly proportional to the movement effort. The muscle distance is directly proportional to the distance. This much clear, guys?
Yes, sir.
Okay. So probably I will plan with some drawing example or writing something and explaining it. It makes more easier. We'll figure out in upcoming classes. So this much is clear, I think. This is what I'm talking about. This is mechanically advantage position because effort arm is more than the resistance arm. Right? So this is fulcrum. This goes as closer to the object, it's easy to move. It goes, fulcrum is moved this side as much as possible, it's tough to move. Okay, keep this in mind. We'll talk about lever system very clearly in upcoming classes, nothing to worry. Okay. What are 1, 2, 3 joints? How can you identify, apart from the general example, what all the other joints are there, how it works, how can we understand the movement, everything we'll talk. So this much understands or clear from yesterday's class. And will give more clarity on the agonist antagonist principle. Okay, look at this video very clearly. I have a back pain. So I have a restricted forward flexion and knee.
Video clearly. Quickly we'll do retest.
Knee
But I'm not
extension
going to
angle
stretch
because
my
of the
hamstring or
sciatic involvement, the
I'm going to
posterior chain
activate
restriction.
my quadriceps.
Okay,
and
but
dorsiflexor.
you can see that very clearly here.
Yes.
See, my left leg, I tried to extend, it was not extending. Okay, but here I can perform nerve gliding, releasing any other manual therapy technique, but I didn't do that. What I did, I activate the same side quadriceps because which muscles are not allowing me? Hamstring and calf, glute, hamstring, calf. So I decided to this is one of the examples. Just I decided to activate my quadriceps and tibialis rise, the dorsiflexors. As soon as I activate the quadriceps, to contract the quadriceps is the active movement, actively effective contraction of the quadriceps required active lengthening of the hamstring. It's not a passive. Active lengthening of the hamstring. Active activation of the tibialis anterior dorsiflexor. It's required active lengthening of the soleus and gastro. Okay. So the muscle was relaxed. I did opposite muscle work. This muscle was relaxed. Now I'm rechecking after activating the quadriceps and everything. Immediately, I can extend.
Range was improved a lot. There is slight.
See, slight niggle was there still, but far better than which we seen before. Immediate results. So I'm not here to ask you to go for immediate results. So this is what the basic concept we are missing in our rehabilitation. Our rehabilitation. Agonist, antagonist, synergist and everything. So beautifully when we see, just for my example, 2 days back when I came to Chennai, I have seen one Indian hockey player who came for the some other matches. Previous former Indian hockey player came for some other matches. He got hip flexor strain. Hip flexor strain, and he asked me the situation everyone faces in our clinical practice. That's why I'm saying. He came and he wants to play. His team is qualified. The scenario, in original scenario, his team is qualified to semi-final. Last league match, he don't no not necessary to play. Already first 3 match they won. They qualified to semi-final almost, and he was ready to sacrifice the fourth league match. Saturday is semi-final. Sunday can be if he wins. Sunday can be final. This was his situation. Hip flexor got strained. It was grade 1 to 2. There is a less chance of making him to play because severe pain when I do resistive testing. And I understand. So he asked me, do you put dry needling? And I educate him. This situation everyone faces. I educate him. Without dry needling, I'll try to make you play. If I put dry needling now, you will feel pain-free reduction. You will not feel the pain. But when you play, you want to move forcefully. At the time, what if the grade 1 tear goes to grade 2 or grade 3? You have to stop playing for another 3 months. Is it okay for you? So he said, okay, he understand, he trust me. And we went to 2 sessions rehab, and today is third session. What treatment I did? If flexor got strained, I extremely activated the glute. Directly, I didn't go and stretch or eccentrically activate the hip flexor and quadriceps. I activate the exact antagonist muscle. Sorry, antagonist muscle. I activate all the antagonist muscles, synergist muscles for the hip flexor. Breathing, psoas major, slightly psoas major activation through breathing, and quadriceps muscle I activated. Also, I activated the hamstring, glute, and everything very clearly. Activated, superbly activated. So much of reduction in pain in the hip flexor, again, even without touching the hip flexor. So after that, I work of the kettlebell based some eccentric work of hip flexor and some sprinting work, mild jogging and everything. Yesterday he sprint literally shorter distance, 10 meter. He sprint, he moved very well. Was so confident now. So what I'm trying to clarify is, so just an help of agonist, antagonist, this model, how we are thinking and applying to the patient plays major role. So we are going to see another couple of examples. This one of the examples suddenly comes in my mind when during my clinical practice of treating. Just I have shared, that's all. And So any movement which is happening, just think about the opposite muscle has to also work. So always I used to say, I was uploaded the video also. Someone asked what is knee extensor. We definitely know there is a quadriceps. Yeah, quadriceps, but not alone quadriceps. Hamstring also a knee extensor. If hamstring tight, also we can't extend the knee. That is what we are saying in terminal knee extension lag patients. Okay, and also keep that in mind. If flexor is quadriceps, that's an isolated movement. The quadriceps is overloaded. Synergist comes into play like a hip flexor. Quadriceps overloaded, definitely synergist comes into play. That's a hip flexor. So every movement have a synergist, stabilizers, and everything. Because of this very isolated movement, stabilization will be done by ligament inside the ligament and everything. Okay, depends on the movement, stabilization vary. Standing knee extension, sitting knee extension, depends on the movement, stabilization of the joint will be different. Okay, so maybe you have the question in your mind, sir, agonist, antagonist, I can decode very quickly. It's not tough for me to decode, but synergists and stabilizers will be tough. Okay, synergist very simple. Synergist and neutralizers are very simple. Just keep in mind, synergist and neutralizer, the muscle which is acting to one primary to the joint. When we learn like a hip extensor is gluteus maximus, secondary extensor is hamstring. Shoulder flexor is anterior deltoid and pec major. Secondary extensor is coracobrachialis. Biceps. We learn the secondary muscles of each joint as a synergist. Shoulder abductor, when we abduct the shoulder, trapezius comes into play as a agonist after 90 degree. When we abduct the agonist after 90 degree, till 90 degree, it plays a synergist role. Synergist role. After 90 degree, demands plays major role of upward rotation of the scapula. To provide more upward rotation, it pulls and helps to contract the upward rotators and shoulder abduction will come. So any movement will happen, the secondary muscle or parallel muscle fibers. Parallel muscle fiber to the joint, to the movement, it works as a synergist. And stabilizers depends on the movement. Same leg extension, you are performing very comfortably in sitting position. No need of stabilization work. The same extension you are doing by squat. Need a core as a stabilizer. We need a core as a stabilizer. Got it? At that moment. Stabilizers really depends on the
last
function.
part?
Yeah, please.
Can you repeat the last part?
Yeah. So when you do the leg extension in sitting, the movement which is happening is knee extension. You are very comfortable at the position to perform the knee extension. No need of stabilization specifically to the joint. Ligaments itself provides some stability. But if we are doing the same knee extension by doing single leg squat, bilateral squat, two leg squat, the core muscle comes into play as a stabilizer. If you move that double leg to single leg, immediately hip lateral muscles comes into play as a stabilizer. Okay. As soon as you do squat, bilateral squat, okay, when you do squat, you are moving the trunk also forward, backward, core muscle. See, everyone do squat normally and breathing and squat, you may feel the difference. Core muscle comes into play. As soon as you move that bilateral into unilateral, see, hip drop will happen. So as soon as when doing bilateral squat, bilateral squat comes under the sagittal plane of movement. Majority of the sagittal plane of movement. As soon as I go to unilateral squat, even though the movement is sagittal, frontal and rotational plane comes into. To provide stability. Here the frontal and rotational planes work as a stabilizers. Got it? Here frontal and rotational plane work as a stabilizers. So this is a beauty which I talk about the myofascial connection, but we'll talk later what I feel. So far it's clear.
Then you said about neutralizers.
Hmm.
That is secondary muscles and parallel muscles.
Hmm.
Parallel muscles in the sense same muscle. If the muscle is also oblique, the same oblique muscle.
Exactly. For example, for external oblique,
Mm.
for external oblique, you are doing some rotational punch. Serratus anterior of same side work as a step neutralizer.
Okay.
Serratus anterior of the same side work as a neutralizer. Because muscle fiber attachment. If you see this, see external oblique attach 1, 2, 3, 4, 5. This 5 ribs. Okay. Serratus anterior comes and attach here.
Okay.
External oblique starts here. Both
Yeah.
in oblique for spiral form it makes. So that time it both works as a synergist.
Okay. Yeah,
For rectus
neutralized.
abdominis, efflexor works as a synergist.
Same
Vertical
muscle orientation, vertical muscle orientation.
Exactly. So vertical fiber, a movement is vertical. Muscle fibers is required. Vertical muscle fibers supports that movement. If your movement is required, rotational muscle fibers supports that movement.
Okay.
Okay. Again, it depends on the movement. Stabilization neutral depends on the movement. Keep on at work. You will definitely get understand, but implement some exercise on your body. That makes more understanding when you treat the patient. Okay. So far clear. Anyone have any doubts? Before moving to the most important part, so I'll give another example of shoulder about agonist and antagonist. So when shoulder joint stability model, okay, let's see shoulder joint stability model, agonist antagonist principle. So humeral head was there. If I ask flexor, what could be the flexors of the shoulder joint?
Anterior deltoid.
Anterior deltoid and pec major can be main contributors of the flexor. But just think, you want to flex the shoulder. Hope everyone can able to see me. Just you want to flex the shoulder, right? Think about osteoarthrokinematics. You have to flex the shoulder. When you flex the shoulder, what if the infraspinatus is attaching to the tubercle? Infraspinatus is not pulling back. What if the infraspinatus is not stabilizing and pulling back the head of humerus? Teres minor and infraspinatus is not pulling back the head of humerus. Head of humerus will fall forward when you flex. You understand?
Yeah.
So now tell me what was the shoulder flexor?
Still flexus remains same, but yeah.
Shoulder flexors
Raise scapular muscles.
infraspinatus and teres minor comes into play.
But there will be
Yeah.
So these are
right?
considered as stabilizers.
Yeah, these are
Stabilizer.
considered as
Stabilizers.
stabilizer.
Dynamic stabilizer, right?
Dynamic stabilizer. Definitely comes into play. I don't know you experienced the shoulder pain patients with any exercise person doing pushing movement causing pain. Pushing movement causing pain or bench press causing pain. If you see any person with involved pushing on bench press causing pain, just randomly check their external rotator strength. Activate the external rotator and ask them to push, they don't feel pain. That is a very, very, very important component. So the posterior rotator cuff work as an flexor of the shoulder joint. So when I ask you what was the extensor of the shoulder joint, now see this is a agonist, this is an antagonist, this is a stabilizer.
Yes, sir.
Here we can add coracobrachialis and biceps. These muscles comes under the synergist. Clear? Now tell me the extensor. If you ask extensor, we say lat, posterior delta, teres major, right? Teres major. But actually, anterior rotator cuff, subscapularis plays one of the important role as a extensor. Because when shoulder extended, subscapularis has to synergistically activate the head to pull forward.
But sir, we will consider that subscapularis as prime movers or what it is, stabilizer.
Stabilizers we can say, but mover is a better example also. But people get, because I used to say the anterior subscapularis muscle is a antagonist.
Antagonist.
Rotator cuff muscle, infraspinatus, posterior rotator cuff muscle is the antagonist of flexion. Why I am saying this? Because it has to eccentrically lengthen to control. Actually, because that is deep science understanding. But if you're thinking that the stabilizer also is not a problem. However you can take. That's why throwing athletes, repeated throwing, they have a weak external rotator. External rotation will be lengthened position. External rotator itself they have in a lengthened position because frequent eccentric motions. By throwing athletes have less internal rotation, more external rotation. Throwing athletes have a very lengthened external rotators because
ARD
of
like.
exactly. Eccentric involvement of the external rotator, frequent eccentric involvement of the external rotator, force of contraction according to the muscle length and relationship will be lesser for them. Next, we'll talk about the muscle.
Sir, then in shoulder abduction,
Hmm.
like deltoid, middle deltoid is the prime
Shoulder
movers.
abduction is deltoid.
Okay, then the upper trapezius will come like what it is, like supporting muscle. I mean, like
Yeah. Upper trapezius as a work as agonist after 90 degree. Till 90 degree work as a
till
stabilizer.
90 degree. If we are talking till 90 degree, it will be
a synergist.
yeah, synergist. Then supraspinatus also will come as a synergist, right?
Yeah,
Or
supraspinatus, all the
stabilizer.
rotator cuff comes under the stabilizer, sir.
No, I'm asking synergist.
Synergist, that all the rotator cuff muscle here. Well, shoulder abduction,
All
all
will come as
rotator
a
cuff
synergist
muscle
or
work
a
as
stabilizer.
antagonist, also synergist.
Then what about the stabilizers?
Stabilizers, this is a stabilizers, also an antagonist.
Okay.
Especially because of
Stabilizers and
stabilizers also you
synergist,
can
right?
call as the antagonist. Especially the teres minor and subscapularis, bottom of the head, it pulls down. Yeah.
Why does the rotator cuff get injured? To raise your arm, the deltoid muscle needs to engage. It's well suited for this task, but as it works, it rolls the head of the humerus upward. In a healthy shoulder, this upward roll is balanced by muscles that insert near the head of the humerus from below, such as the subscapularis and teres minor. However, if these muscles don't engage properly, the humerus head will roll upward, reducing the space available for the supraspinatus tendon to slide under the acromion. This increased friction weakens the tendon over time, leading to injury. Find a way to activate the subscapularis and teres minor while raising your arms, and your rotator cuff will heal naturally.
Got it? Well, seeing how it works and everything. But when it comes to patients, completely different. Don't directly think this. Biomechanics is different, patient is different. According to me, always. Biomechanics doesn't teach that patient mentality and psychosocial behavior. Okay, this is what the picture shows now, how it pulls down for translation of the upper. Majorly, we can say infraspinatus, teres minor, subscapularis work as a stabilizer, supraspinatus work as a agonist. Supraspinatus is full range abductor, but not only initial degree, but that is we can talk again many things. I think everyone has got clarity.
Yeah, sir.
Clear, guys?
Yeah.
Perfect. So best exercise for, which is the best exercise for rotator cuff?
Rotator cuff exercise.
Sorry?
Any shoulder
Exercises which
movement.
involve rotator cuff movement. I mean, internal, external rotation.
Lateral raises. Varshini said. Beauty. Varshini, where are you?
Sir, any shoulder movement will actually involve.
Any shoulder movement. Yeah, that is the basic understanding. Any shoulder movement, but lateral raises is one of the best exercises for the rotator cuff. And push-ups, rowing.
Oh.
These are the exercises because as we know, abduction is all rotator cuff muscle get activated. When you abduct, all rotator cuff muscle has to pull the head towards the Scapula. Don't go. It has to work a lot of tension. So lateral raise is one of the best exercises for the rotator cuff. So the evidence are there. So many evidence are there. When the person flexes, they kept EMG needles on the studies or electrodes on the back posterior rotator cuff muscle. Ask the person to flex. Posterior rotator cuff muscle activation was so much. And ask them to extend anterior rotator cuff muscle activation is so much. When they abduct, all the rotator cuff muscle activating much. This is a study based. Also, we have a lot of study. Oh, I don't know. We will not learn this kind of things in our colleges. But if we can apply this into clinical practice, we don't depend on any passive options for any patient with any problem. That is what I always say. So hope this much agonist, antagonist, stabilizer, neutralizers, everything is clear. Perfect.
Sir,
Yeah,
you said that the lateral raise is the best exercise for rotator cuff, correct?
exactly.
Anyways, when we are doing abduction without any weights, the pre-abduction, the rotator cuff are not able to stabilize the humeral head. That's why it's giving that impingement. And over that, we are doing the lateral raise, which is again a kind of abduction. So don't you think it will increase the pain?
Any special test if we perform, we are going to aggravate the problem. Every special test same now. If we consider in that set. Already person have ACL injury. What is the purpose of doing anterior dryer test or latchman test to track more? Grade 1 is to grade 2.
But that's, we want to check if the injury is there. Here we are again giving the lateral raise. Abductor is the rotator cuff is already not
so
able
your
to
question is
stabilize.
how you rehabilitate this person. Now I will go for isolated rotator cuff activation. The already person come with unable to lateral raise has pain. Mean I will go for isolated activation. I activate manually, slightly external rotator, internal rotator, slide abductor, available range of motion, brain free range of motion. Slowly I will train the muscles in a non-abductive position, and then I ask the patient to abduct. It will be easy for them.
Okay, so first we'll go for the specific movement like rotators.
Isolated activation. That helps.
Okay, understood. Thank you.
So when it comes to impingement, the Hawkins-Kennedy test or painful arc sign not only helps to predict that shoulder impingement. Now what I'm going to say maybe surprise you. This only testing helps to predict if the person painful arc sign is positive. Hawkins-Kennedy test is positive. Infraspinatus and TVS minor resistive test is positive. All three positive. 95% of validation the test which has. Even though out of 100 people, 5 people is diagnosed wrongly. So keep that in mind. Special tests are not so special. Always. Patient history taking and everything is plays major role. So as soon as someone put the human into play, as soon as you put some human into play, you are asking me the person already can't abduct the shoulder and how you start. Yeah, I give an answer of other muscle activation and everything. That may be an answer according to the biomechanical concept. Let me answer according to the biomechanical. As soon as some human comes into play, how much their past experience of the pain, understanding of the individual pain, what was the history, so many things comes into play, and also it influences the rehabilitation. Because your pain and my pain is not same, just I'm adding. So biomechanics helps to understand the movement well, but very surprisingly, there is no shoulder impingement happening. Should not call it as a shoulder impingement, first of all. It was revised in 2016 itself. That is a big story. That was. I'll talk about the shoulder. I can talk 2 days about the shoulder only. But just keep that in mind. Lot of information. Just after watching this video, you people may go and see today's patient come with complaints of shoulder pain. They can't able to update. You immediately think to activate the infraspinatus and TDS minor subscapularis. You're wrong. That is not a real learning.
Actually, it never happens when we apply in patients.
Sorry?
As you said, if you directly strengthen the infraspinatus and it's never going to ease the patient's pain because it never happen.
Yeah, again, it depends. The actual problem is that immediately the person can feel better. The actual problem is not that the person's psychosocial behavior also have to comes into play. The way history collection, everything comes into play.
But sir,
Yeah, tell me.
it is true that when someone is trying to lateral raise the arm, so when this supraspinatus is inhibited, that upper trapezius will overwork and
Beauty. Exactly, you're right, Gaurav. That is the one of the most scenarios. Or if your deltoid is weak, you will end up having the neck pain.
okay.
If your neck muscles are weak, you will end up having the shoulder pain.
So all this is the couple force work which works in the.
Force couples I'll talk separately. The upper rotator force couples, scapula, upper trapezius, lower trapezius, and serratus anterior house comes into play. That will be discussed separately.
Okay, okay.
Now what I want to say, in PA shoulder cases, they can't lift more than 80-90 degree.
Yeah.
Right. So trapezius doesn't comes into play only. After that only trapezius will comes into play. They overuse the deltoid. They overuse the deltoid, and all the PA shoulder patient comes and complain pain in the deltoid region, unable to palpate.
Yes, sir. Yeah, one nodule will be there after over pulling. Yeah.
See, if you try to release the deltoid lifelong, the person not feel improved. That's what I will say always. Your deltoid is so weak. Your deltoid is so much weak. You tend to activate the will end up having the deltoid and posterior cuff stability, infraspinatus as a weak. Because human will have asymmetry. Bike riding will have neck pain. Reading will have neck pain. We found out the trigger. We release. Again, it will form because you didn't treat the root problem, which is there already presented. So rather releasing, vinyling, cupping, IFT, taping, something, just activate the shoulder, strengthen the shoulder. Trapezius pain will not come next time. This is what I always say to everyone. This is one of the beauty. Again, this is what the synergist component comes into play, because trapezius muscle work as a synergist for elevating the shoulder. Elevation of the shoulder or stabilizing the shoulder doesn't have a proper control. Trapezius will overactivate. What if some muscle overactivate very frequently? Muscle tightness will be increased. Actin myosin binding will be more. It was tight. We called that as a muscle knot and trigger points, and we are releasing the trigger points. What was the culprit of forming the trigger point? Treat that culprit, the trigger point won't form again. Okay, the deep understanding. In my past 3 years of clinical practice, this is a deep understanding which I got. See, it depends on how much the person loading, how frequently the person is moving through their lifestyle, what was the person pain threshold, pain tolerance, that plays major role. The trapezius also is overloaded, it goes to upper neck. Upper neck also overloaded, it goes to scalp fascia. This is also overloaded, it goes to eye. It is also overloaded, it goes to jaw muscles. It is also overloaded, person complains chest. Anterior muscle compensation will be there. It is also overloaded, biceps comes into play. It is also overloaded, forearm comes into play. It is also overloaded, thenar comes into play. We are calling that is a myofascial pain syndrome. We forgot that it all started because of shoulder weakness.
Okay, the myofascial lines.
Yeah. So it's spreaded. See, the people who have a lot of activity involving on the forward bending and doing certain activity, or some glute engaging activity, one side unilateral weakness in the glute, they tend to overuse the hamstring and the erector spine. We may found the trigger point in erector spine and hamstring, and we are releasing, but we're not treating the root problem. Again, the person do the same activity. The person pain threshold is very much. They're not feeling much pain because these pains are dull, aching. People will take longer to come and meet you. It's not a sharp pain to immediately next day. Oh, I have severe pain. I will come. No, the dull, aching pain. They take time, 3 months, 6 months, 4 months, and they will come. By the time erector spine goes to neck, hamstring goes to feet, full posterior chain involvement will be there. You may thinking that's a myofascial pain syndrome. Yes, that's a myofascial pain syndrome, but the problem is glute weakness. Find out this very tough. This is what I'm trying to say. Everyone have unilateral hip weakness. If ask you to stand on a single leg, which leg we confidently go first, that leg we have confident leg. Other leg have definitely weakness. If we have that side, lateral side pain, one side back pain, you may think that we will blame the QL, release the QL. But if I palpate the QL, releasing QL is impossible. Second thing, because of the hip weakness, you tend to overload the QL. Yesterday I said, show the picture. This deep understanding should come from this agonist antagonist stabilization model and principle and everything. This is what I'm thinking and trying, asking you to educate and everyone. So biomechanics is different, psychosocial is different. Both have to engage together and practice in a different way. Through movement, it's completely different. So far, it's clear.
Yes, sir. Very nice.
Sir.
Beauty.
Beauty. Thank you.
Excuse me, sir.
Yeah.
Sir, I know you explained so much, but one primary doubt I have in this picture. So you've written, see, for flexion, it's pec major and anterior deltoid. On the opposite, you've put in the box, right? So those are stabilizers or antagonists?
Both.
Okay.
So just think that's a stabilizer.
Stabilizer, but also dynamic, I'm sorry,
Yeah.
dynamic
Also, it
stabilizers and
lengthen.
antagonist.
Also, it will lengthen to pull like it works as a concentric eccentric mover motion also. That is what.
Okay, it went a little over my head, so.
No, correct. You're right. I was absolutely trying to say to you all stabilizers only. As Jeffrey sir asked, so I add the point also as antagonist because I won't want to confuse you. Just stabilizers. Think stabilizers that works well.
Okay, because for me, in my mind, it was mainly antagonists more than stabilizers.
Yeah,
So that's why.
antagonist and stabilizers both comes into play. You are right.
Okay.
You are right. Okay, guys. Now, another 10 minutes, just chill. This is extra class because net muscle action. We are going to see next is net muscle action. Net muscle function, length tension relationship, force tension relationship. If we learn this pakka, movement is very easy. Okay, then again, neural consideration, GT apparatus, motor unit, and Golgi tendon organ. These are all things we'll see. Neural adaptation principles and everything we see. Motor learning concepts. And we'll end the neural consideration and we'll go to specific joints, liver system, and Newton's law and everything. We read torque, force, velocity, acceleration, relationship, everything. So we'll get more understanding. We'll try to decode the movement. We'll learn more and more about the movement. Okay.
Sir, I have one doubt. It's,
Please.
I mean, off the topic, but I would like to ask it.
Hmm.
Are stiffness and tightness the same?
Stiffness and tightness are same. It's a big question. Little bit same, and depends on the person's perspective.
Okay, then are tightness and weakness the same?
Same.
Okay, so stiffness
Again,
is
it will differ a little bit according to the person.
okay. I'll tell you my understanding. Correct me if I'm wrong.
Hmm.
So if there is overuse of a muscle and there is too much actin myosin bonding, that comes under stiffness. But if there is a neuromuscular,
No. Overuse of the muscle. Tell me again, overuse of the muscle.
if the muscle is overused,
Hmm.
can we call that stiffness? And if a muscle is not able to perform its function because there is not much trigger, I mean, there is not much action after the neuromuscular trigger, can we call that weakness?
Yeah. Second, weakness is correct, but first you said stiffness also comes into place of tightness. But
Okay.
tightness, weakness is highly depends on the individual. Why I'm saying this? Because I have seen people who can able to bend forward and touch the toes very comfortably.
Okay.
They said I have tightness. Back of the muscles. People who can't even reach the toes, they said to me, I am feel free, good.
Okay.
So biomechanically, when speak, you're right.
Okay.
When person comes into play, it may differ according to the person.
Okay, sir. Thank you.
Sure.
Where can I learn more about dynamic stabilizers and stabilizers per se?
In my anatomy class.
Oh, okay.
No, just I'm joking. We shared one book, na?
Okay. Yeah.
Joseph Hamill.
Yeah.
Try to read the book, upper limb, lower limb, trunk, everything.
Okay, sure.
It gives more clarity.
Yeah, because I don't have very like good understanding about stabilizers, so that's why.
No. Stabilizers, don't think about the stabilizers. The person is running unilaterally, gluteus medius comes under stabilizers. Person is standing, core comes. Because according to the situation only stabilizers work. According to the moment demand, resistive force only stabilizers work. When we talk about the net muscle action, you will understand more clearly. Once we complete net muscle action, everyone get clarity. What is concentric, eccentric, isometric? If you know this, everyone will get clarity. Perfect clarity.
Okay, sir.
Okay. We'll wait for that.